Stephanie Manley. I'm one of the nurse practitioners with the inpatient urology department. I am here to talk to you guys a little bit about hematuria and CVI education. The reason I'm doing this is we've had a few episodes this summer where catheters weren't placed properly, where we started continuous bladder irrigation when the bladder wasn't actually catheterized correctly. And we've had times where CVI has been started and the bladder's full of clots. So I want to just kind of show you how to properly do this and what to look for with bloody urine to know if you need to be concerned or not. So the most important thing is patient safety. So when a patient comes into the ER and they're having complaints of hematuria, you want to ask yourself, what does it actually look like? Because to a patient, any color red, pink is bloody. To me, when I see someone come in and says their urine's like brown or really dark colored, it's usually a sign they're concentrated and very dehydrated. If they complain of tea, like iced tea, then it's usually old blood. If they refer that it looks like pink lemonade, that's just a little bit of blood, and that's not concerning. Fruit punch is not concerning, even though it's bright red, but as long as you can still see through it in the toilet, it's not concerning. We start getting concerned when it starts looking more like a Merlot and it's getting thicker. And the most concerning thing is when it comes in and they're describing it as ketchup or barbecue sauce, because it's so thick and you can't see through it, and that's usually a sign that there's active bleeding. The second thing you want to be looking at is, are the patients in retention? Just because they're having bloody urine doesn't necessarily mean they need a catheter. If they're not emptying their bladder and they're retaining more than, say, 250 milliliters, then that's concerning for clot retention. That warrants a Foley catheter inserted, and then consider CBI, which we'll get to in a minute. If they're not in retention, nothing to be worried about, all right? As long as they are urinating and evacuating, even if it's bloody, generally it's something that just needs a workup as an outpatient, and they need a referral to the urology office. So, say your patient comes in, they cannot urinate, they're complaining of dribbling, bright red, bloody urine, they describe it, even, ask them, does it look like ketchup or barbecue sauce? And they say yes. You get your catheter in and not much comes out. Before ever starting CBI, the most important safety thing that you can do is make sure to irrigate their bladder first. If you would start continuous bladder irrigation and the catheter is not confirmed in the right bladder, you potentially are irrigating a false passage and causing serious damage to the urethra or the prostate gland. If the catheter is in the bladder and you still want to start continuous bladder irrigation and there's clots in there, all you're going to do is potentially stir those clots up, block the eyelet of your catheter, and then just fill their bladder like a giant balloon. And eventually that bladder is either going to rupture or they're going to have horrible flank pain, and then it's going to be another bigger problem than we started with. So I'm going to show you how to irrigate a catheter. So pretend this is our bladder, and you've got your catheter in. You've got 3 ports. This port is your balloon port. It usually holds about 30 mLs of saline, okay? You don't have to have it full max 30 to irrigate. You can have anywhere from 10 to 30 in there. The middle port is the one that you're going to irrigate with. That's your outflow catheter port. And the little one here on the side is your inflow. That's where you'll hook up your irrigation when you're done. You don't have to worry about that one right now. So my bladder's full. So what I'm going to do is I'm going to fill a piston syringe, connect it to the middle port, and I'm going to flush it in. And I'm going to do 2 to 3 of those. I'm going to pinch it off so it doesn't come back out. But 2 to 3 syringe fulls before I pull anything back. Because if you try to just pull it back, what you're going to do is actually suck the bladder wall right up against your catheter, and that causes spasms and pain for the patient. So if they can tolerate 3, great. So you get your 3 in there. So next thing you want to do is to suck it right back out. And I apologize, it's clear water, so it's not going to do the effect. Let's see if it'll stay. Might need a hand to hold that in. Stay in there, catheter. There we go. So you want to fill it up and suck it out. Generally, you'll keep doing this. You'll suck it out, squirt it into your waste bucket, and keep sucking it till you meet resistance. And then you start again. You suck your flush irrigant, and you put 3 syringefuls in.
What do you want this irrigant to do?
Normal saline should be what you should be using. If you don't have liter bottles of sterile saline, then you can use sterile water. Either is safe. But yeah, you want to keep doing this process, 3 in and then pull them out until you actually run out. And you keep doing this process until you know for sure there are no more clots in there, because there are times that you may irrigate 3 in, take 3 out, 3 in, 3 out, and do this for 10 or 15 times, and then all of a sudden you'll get a syringe full of clot. And that's because you stirred everything up by the repetitive process of in and out. And you keep doing that until the urine actually looks almost pale pink or the same color of what you're putting in there. As long as it's still red, it's not necessarily cleared yet. Sorry about that.
You got urine on yourself.
Yeah, that happens. Job hazard.
You're in trouble.
Oh. So I just want to make sure everybody does that before they actually hook up irrigation, because if there is still concern for bleeding or blood clots actually in there, continuous bladder irrigation is not designed to evacuate clots out. And that's the number one thing I see wrong, and that's across the hospital, is they see bloody urine, they put a 3-way in, and they start CBI. And what happens is, a few hours later, they're like, oh, it's cleared up because what's coming out the bag is exactly what's going in the bag. And that's not correct. What's happening is that clot's sitting in the pocket back corner of the bladder, and the irrigant's coming in and right on out. It's not productive. CBI is there to prevent clots from forming. Just like you don't want your finger to keep bleeding, you run water over it, you're just slowing the bleeding down. You're not actually flushing the blood clots out. That is what this is for, manual irrigation. It's very important. There are different types of 3-way catheters. I just want to reiterate that. Obviously, you want to try to get a larger catheter in at 22 or 24, because the actual inside tubing, if I would actually cut this in half, this is about the size of an 18 French actually. If you put, say, an 18 French 3-way in, the actual tube that's draining the bladder is only about the size of a 14 French. And you don't want that. It's not going to be productive. So a 22 or 24 is best. This one's a 20, so this one's a little small. I understand some of these men and women have narrow urethras. You can get in what you can get in. Also, the difference is this one is a standard 3-way catheter. As you notice, it's just a regular tube. You've probably seen ones that have stripes, like tiger stripes all through here. That's a hematuria catheter. It's a bit excessive for the average person. All right, usually you don't need to put that in unless a urologist tells you to do so. Generally, this is sufficient for irrigating a catheter before admitting them to the hospital for CBI. Let's see here. If you ever have questions about setting up CBI, irrigating a bladder, you're just not sure, don't hesitate to call me Monday through Friday when I'm here during the daytime. If it's in the evening or afternoon and I'm not here, my 2400 charge nurses are always available by phone, and they will coach you through it or even come down and help you make sure everything is set up properly. Because the last thing we want to do is set it up incorrectly, as I said, patient safety, and you want to make sure that you don't let your bags run dry. So a nifty trick, when you do get it all set up and you're ready to go, you've irrigated your patient, you know there's no more blood clots in there, when you hang your bags, make sure both clamps are open and make sure one bag is higher than the other, like you would a piggyback. Because that way one bag will drain faster than the other and you're not running dry on both bags and realize I got tied up in another room and my irrigation has stopped. Again, if you have questions, don't hesitate to call or email me. I'm here. I want to help you guys. I want to make sure our patients are safe and have good care. We don't want them having any further complications. We don't want to have unnecessary surgeries if we don't have to. This is something you all can do as nurses. And again, if your residents or your doctors tell you to do something, you can advocate for your patient to make sure they get the time and proper care to irrigate their catheter safely.
Awesome. Thank you.
Thank you.